Good afternoon, everyone. Welcome back to another episode of Pathagonia. Thanks for tuning in. So today, I'm going to record a video on upper aerodigestive tract squamous lesions. And let's get started. So in general, there are both benign and malignant conditions that can sometimes have similar clinical appearance in that area. So some terminology. First, you have leukoplakia, which is a clinical term for a white plaque on a mucous membrane. We also have erythroplakia or plakia, which is a clinical term for a red plaque with a higher risk of dysplasia, and speckled erythroplakia, which is a clinical term for a mixed red and white lesion. This may represent a wide spectrum of histologic changes, often falling within the general category of keratosis, with abnormal presence and or excessive keratin with or without dysplasia. And any type of lesion may be biopsied to evaluate for malignancy or dysplasia. So some non-neoplastic lesions is our first category. These may mimic cancer clinically, often with leukoplakia or ulceration, and the first of which is a classic, so candidiasis. So candidiasis is the most common oral fungal infection, often occurring in immunocompromised patients, but it can occur in healthy individuals. It often appears clinically like a white plaque, with dimorphic fungi with yeast forms and hyphae or pseudohyphae, leading to hyphal form, which causes tissue invasion and symptoms. So you want to look for the hyphae to make your diagnosis. And yeast only is not good enough. You also want to see the hyphae or the pseudohyphae, like we see here in this image with the arrows. You often see candidiasis with parakeratosis and acute inflammation. So consider this diagnosis and do stains whenever you see those findings. And you can highlight candida with PASD or GMS, and you may see accompanying reactive epithelial changes like hyperplasia. Next up, another classic, herpes simplex virus. So the virus infects epithelial cells and ganglion cells. There are two types classically infecting different sites. HSV-1 is an oral herpes, while HSV-2 is genital, but that's not always true. The infected cells show classic ground glass intranuclear inclusions with the 3 M's, which are molding, margination, and multinucleation. And this is the classic image that you could see for a herpes simplex virus infection with those 3 M's. You see the molding, the multinucleation, and the margination of chromatin. Herpes is often associated with ulceration with acute and chronic inflammation. And CMV can cause similar ulcers, but is much rarer and is usually only seen in the immunocompromised, and the eosinophilic intranuclear inclusions are seen in mesenchymal cells in CMV, where we already discussed in herpes that it's an infection of the epithelial cells. Moving on, lichen planus. So the same as on the skin, where you can have lichen planus, it often also involves mucous membranes. It is a chronic, self-limited inflammatory reaction, multifocal. If it's focal, it's considered lichenoid keratosis. In lichen planus, you get that band-like T-cell infiltrate with the sawtooth reedy ridges that we see here, kind of coming down on a sawtooth pattern, and that lichenoid interface pattern that we're also appreciating here. With lichen planus, you often have hydropic degermination and or degeneration of keratinocytes with no significant atypia, and otherwise you want to consider dysplasia. There's variable thickness in keratinization in lichen planus, and it's of unknown etiology, although associated with many medications and hepatitis C. And you want to remember the clinical 5 Ps that we learned in medical school. So purple, peritic, polygonal, planar, and papules. And those are buzzwords to make you think about lichen planus. Next entity we'll talk about is hairy leukoplakia. So this is epithelial hyperplasia induced by the Epstein-Barr virus, often on the lateral tongue of immunocompromised patients with acanthosis and parakeratosis. You have balloon cells in the spinous layer with viral cytopathic effect, including eosinophilic nuclear inclusions and ballooning degeneration, highlighted by the Eber in situ hybridization, or the ISH. Often co-infection with Candida is present, and there's little inflammation and no dysplasia. And this is what hairy leukoplakia can look like. You can see the acanthosis, or the thickening, and then you also have this parakeratosis with these small pycnotic nuclei up top, classically associated with EBV. Next up, we have geographic tongue. So this is also known as benign migratory glossitis. It's an idiopathic inflammatory condition primarily on the tongue, often asymptomatic and commonly self-resolves. There are multiple well-defined erythematous islands with raised whitish-yellow borders that rapidly appear and migrate around the tongue. The epithelium has hyperparakeratosis with acanthosis, spongiosis, elongated reedy ridges, and collections of neutrophils or Monroe abscesses. And the lamina propria can have acute and chronic inflammation. So this is what it would look like in the patient. You can see why it would be called geographic tongue. Maybe this could look like continents or various things you would see on a map. So interesting name for an interesting diagnosis. So moving on, we'll just do a quick review of what would we look at kind of at a cytology perspective to differentiate reactive versus dysplastic changes. And these are fundamental concepts that are important to review no matter what your level of training are. So for benign or reactive entities, you think eggs. So the cytology is, although they may enlarge if you have benign or reactive cells, the nuclei are still rounded with smooth nuclear contours. They commonly have low end-to-C ratios with more cytoplasm, and as mentioned, the nuclei are smooth with round oval appearance and often with speckled chromatin, like this egg. And sometimes they have a prominent nucleolus in benign or reactive, and you could think like that is the yolk in the egg. And is there lots of inflammation? If so, raise your threshold to account for reactive changes. Because, for example, in the cervix, commonly on SurgPath, you could see some cells and you think, oh, are these dysplastic? Is this low grade? But you see a ton of neutrophils and a ton of inflammation. I was always taught, we're trained at my institution to, like Dr. Schauberg says, to raise our threshold and kind of account for that reactivity that we're seeing with all that inflammation. So it's going to be harder to get to dysplasia if there's a lot of neutrophils and a lot of inflammation in that area that can explain some of these cytologic changes that we're seeing. So for architecture, it often matures towards the surface with the highest end-to-C ratio cells confined to the base, and cells seem to know which way is up. So this is in benign and reactive things. Things are maturing appropriately, and it's polarized and doing what it should be. However, in the dysplastic category, you want to think boulders. So cytology-wise, the nuclei are big, with irregular, jagged, rough, and dark appearance. High end-to-C ratios. It's mostly nucleus that you're seeing. The nuclei are dark with irregular, crinkled contours. You'll have dyskeratotic cells and usually no nucleoli unless perhaps it's invasive. And architecturally, there's no maturation in the traditional high-grade dysplasia. It's just high end-to-C ratio cells all throughout the epithelium. Many cells don't know which way is up, so it's very haphazard and disorganized. However, you can see maturation in low-grade dysplasia and keratinizing dysplasia. So keep those principles in mind as we move forward. Next category is squamous neoplasms, non-HPV related. So the majority of the oral cavity, the larynx, and the pharynx cancers are squamous cell carcinoma. The major risk factors are smoking, alcohol, and betel quid chewing. So this synergistically increases the risk together exponentially, not just additively. Often clinically, the appearance is white to erythematous, with erythematous lesions often being more frequently dysplastic. And genomically, they're unstable with chromosome gain or losses, frequent mutations in TP53. So for squamous dysplasia, you have epithelium with accumulated genetic changes, which leads to a risk of progression to squamous cell carcinoma. The non-obligate precursor leads to most cases of dysplasia do not progress to squamous cell carcinoma, and the higher grade equals the higher risk. So features of nuclear and cellular atypia are marked variation in size and shape, marked hyperchromasia, and prominent nucleoli. The epithelium may be atrophic or acanthotic, keratinizing or non-keratinizing, and you want to grade it using the scheme below based on maturation. But if there's severe atypia, it is acceptable to upgrade to high-grade dysplasia, even if it matures at the surface. It's not always reproducible, so consider showing another person if it's important. So low versus high-grade dysplasia in squamous mucosa is something that occurs in so many different areas throughout the body, and it's such a foundational concept to review and to go over, so these notes are extremely helpful. So for low-grade dysplasia, previously known as mild dysplasia, has a low malignant potential, typically limited to the lower half of the epithelium with surface maturation. And remember, while these notes are for the upper aerodigestive tract, a lot of these concepts, like I said, can be applied to cervix and other areas in the body. So these are really just basic premises to approach your diagnoses with, so they can really be applied broadly. For architectural criteria, stratification is preserved with retained orientation. The cytologic criteria, at most, there's minimal cellular atypia in low-grade dysplasia, and mitoses are rare with few dyskeratotic cells. However, in high-grade dysplasia, previously moderate to severe dysplasia or CIS, this is a pre-malignant lesion, and it involves at least half of the epithelium, and it may be full thickness. There's architectural criteria. You'll have abnormal maturation, altered cells involving greater than or equal to half of the thickness, disordered stratification. It can be keratinizing or non-keratinizing. And for cytologic criteria, there's conspicuous cellular atypia with increased indice ratio, increased mitoses, and dyskeratotic or apoptotic cells throughout. So just at low power, you can appreciate there's some dysplasia occurring in the low-grade dysplasia, but it's confined to the lower half of the epithelium. This all up here looks okay and benign. In high-grade dysplasia, this is all dysplastic. All this hyperchromatic high indice ratio cells is totally not what you want to have, a pre-malignant lesion, and it's basically full thickness. So that would be high-grade dysplasia. Next up, we've got proliferative verrucous leukoplakia. This is a multifocal progressive disorder with a very high rate of recurrence and transformation to squamous cell carcinoma, often occurring in older females with an unknown etiology. In the oral cavity, it often involves the gingival, alveolar mucosa, and the palate, with appearance changes with time. So it starts with a localized flat or verrucous hyperorthokeratosis, often lichenoid interface mucositis, and eventually becomes multifocal and develops dysplasia. The diagnosis often requires clinical and pathologic correlation, as findings on one biopsy are not diagnostic. You must know multifocal, and it can be progressive. It may progress to traditional or verrucous squamous cell carcinoma. And this is a proliferative verrucous leukoplakia. Next up, we've got conventional squamous cell carcinoma. So this is a malignant epithelial tumor with squamous differentiation. You have your keratinization, or your beautiful keratin pearls that we see here, and or intercellular bridges. So some features of invasion are downward growth of islands, cords, and isolated tumor cells with irregular interface and desmoplastic response, LVI or perineural invasion. And grading is irrespective of keratinization. So for well differentiated, it closely resembles normal squamous mucosa, matures somewhat normally with few mitoses. Moderately differentiated, there's more pleomorphism in mitoses. And poorly differentiated, you have basal type cells predominant with lots of mitoses and often losing expression of the high molecular weight cytokeratins. Depending on the location, it can present with a mass in the oral cavity, or hoarseness in the supraglottic larynx, or dyspnea or stridor in the subglottic larynx. It frequently metastasizes to cervical lymph nodes. So lymph node met is the single most adverse prognostic factor. With extracapsular extension, is it particularly associated with regional recurrence and worse survival. Next up, we've got verrucous squamous cell carcinoma. So this is a variant of well-differentiated squamous cell carcinoma with dramatic acanthosis with club-shaped projections and invaginations. There are marked church spire keratinization that we see here. There's no significant cytologic atypia, but there are proliferative basal cell layer of only 1 to 2 cells thick, and only very rare mitoses in the basal layer. There is well-defined pushing invasion, often with associated lymphocytic inflammation, and there is no infiltrative growth. You often need to see nearby epithelium to show relative invasion beneath the basal layer of the nearby epithelium, and it is locally destructive or invasive but does not metastasize. It may be very hard to diagnose on small biopsies, requiring clinical correlation, and if there's clinical concern for malignancy but the biopsy looks benign, consider this diagnosis. If there's infiltrative growth, it could be, or it is at that point, a conventional squamous cell carcinoma. Another variant, we have spindle cell squamous cell carcinoma, also known as sarcomatoid carcinoma or carcinosarcoma. This is squamous cell carcinoma variant with predominantly malignant spindle and or pleomorphic cells, often an ulcerated polypoid mass, and the epithelial to mesenchymal transition occurs. You can have heterologous differentiation, and you must have evidence of epithelial differentiation, either by morphology or by IHC. And there's a similar prognosis to conventional squamous cell carcinoma. So some other variants, I'm not going to read all of them, but you can have a basaloid squamous cell carcinoma, papillary squamous cell carcinoma, adenosquamous carcinoma, and lymphoepithelial carcinoma. So just be aware of these. You can look up good images, and they could definitely show up in practice, and we would want to get to the correct diagnosis. So next up, we've got HPV-related squamous lesions. So another classic is verruca vulgaris. Vulgar, I believe it is Latin for common. So this is the common wart, verruca vulgaris, and it's a benign squamous proliferation in the oral cavity caused by low-risk HPV, types 2 and 4, identical to that on the skin. It is exophytic and papillomatous with hyperkeratosis and acanthosis. There are elongated and cup-like reedy ridges. You can kind of see this intowing and cupping of the reedy here. You can appreciate that. And it's cytologically bland with prominent granular layer and occasional coilocytes. For condyloma acuminatum, the oral equivalent of anogenital condyloma with HPV type 6 or 11, often sexually transmitted and often larger than verruca vulgaris. Another entity is multifocal epithelial hyperplasia, or HEX disease. Multifocal benign squamous proliferation in the oral cavity caused by HPV. It is most common in children or adolescent girls with HPV types 13 or 32. It's often located on the lips or the buccal mucosa with multiple papules. There can be mild hyperkeratosis, prominent acanthosis, normal cell maturation, and occasional coilocytes. The mitosoid figures are hallmark, not often seen in other conditions. As you'll see here, the mitosoid figures. Kind of bizarre looking mitotic activity. And that is HEX disease. So next up, we've got squamous papilloma. So squamous papilloma is a benign exophytic squamous proliferation with branching fibrovascular cores. It's usually associated with HPV type 6 or 11, and you can get it through sexual or non-sexual contact with variable coilocytes that may be obvious or subtle. They are often solitary, and malignant transformation is very rare for squamous papillomas. If they are multiple, especially if young, consider recurrent respiratory papillomatosis, or RPR, which is multiple recurrent papillomas in the respiratory tract of children and young adults, leading to high morbidity as it can obstruct breathing and swallowing. And you can see this papillary formations with the classic fibrovascular cores. Of course, you'd want to assess for cytologic atypia and look closely at it, but that's good for a squamous papilloma. Within the HPV category, we have squamous cell carcinoma, HPV-positive, which is squamous cell carcinoma associated with high-risk HPV. Over 90% are caused by HPV type 16, associated with oral sex, and the incidence is rising, frequently in white men in their 50s, with a strong predilection to the oropharynx, the base of the tongue, and tonsils. It often presents at a high clinical stage with a small, occult, oropharyngeal primary and cervical lymph node metastases, which are often large and cystic. There's a distinct morphology, which is non-keratinizing, high indice ratios, and kind of a basaloid appearance. Frequent mitoses and or apoptotic figures can be seen, and there are frequent associated lymphocytes and lymphoid stroma, and some morphological spectrum as it can be papillary and other formations. This arises in the crypts of the tonsils, and it grows and invades as nests or lobules. There is no recognizable in situ component or background dysplasia, and grading is not applicable. HPV can be detected by in situ hybridization, or ISH, or PCR. So diffuse block positive staining with P16 is used as a reliable surrogate marker for the presence of high-risk HPV and oropharyngeal carcinomas if the morphology is appropriate to test for it. A significantly better prognosis than conventional squamous cell carcinoma. And just some chart for your own review. I'm not going to go through all of it here, but it's adapted from the WHO head and neck section. And some of the differences on HPV-positive squamous cell carcinoma versus HPV-negative squamous cell carcinoma. So be sure to reference this, make flashcards, whatever you need to do just to lock that information in. So lastly, let's just talk a little bit about staging. So there's some important staging details. You want to be sure in this area that squamous mucosa of the upper aerodigestive tract, you want to make sure to